Started? Okay. Welcome back, guys. Now we'll be discussing about most important MCQs from the physiology for the upcoming FMGE exam. See, these questions were designed in such a way that they are integrated with the patho as well as the medicine, because these days, they are not asking the direct questions. Most of the questions are in integrated pattern. So these questions that I'm going to discuss right now, they are also integrated. Okay, and these are the most important topics. Okay, now first look at the question and go through the options and think which option is the correct answer. Later we can discuss about it. Okay, so first go through the question. Now see, a 60-year-old diabetic presents with a nephropathy. Okay, he's having kidney issues, let's say, and he is started on lisinopril, ACE inhibitor. Okay, he is kept on the ACE inhibitors. After 2 weeks, his creatinine levels rises modestly. His creatinine rises little bit. BP is well controlled. Urine shows reduced microalbuminuria. Okay, everything is fine. What explains this rise in the creatinine levels? Okay, his creatinine levels are going to rise modestly, not too much, but modestly. Why? What do you think is the answer? See, you all know if we use lisinopril or ACE inhibitors, what is the mechanism of action of ACE inhibitors, guys? The mechanism of action of ACE inhibitors, ACE inhibitors inhibits which physiological mechanism? RAS pathway. ACE inhibitors inhibit RAS pathway. Now, whenever the RAS pathway is inhibited, what happened to the angiotensin 2 levels and aldosterone levels? Decreases. So, in this person, angiotensin 2 levels is going to decrease. Now tell me, angiotensin 2, you already know angiotensin 2 is specifically acting on the efferent arterioles. Okay, angiotensin 2 causes what? Angiotensin 2 causes efferent arteriolar constriction, and it maintains the GFR. By constricting the efferent arterioles, the glomerular hydrostatic pressure increases, GFR will be maintained. But today what happens? RAS pathway is inhibited, angiotensin 2 is not available. Whenever the angiotensin 2 is not available, the efferent arteriolar constriction is maintained. No, the efferent arteriole is not going to constrict. So, efferent arteriole will dilate. So, there is going to be efferent arteriolar dilation. Efferent arteriolar dilation. You tell me, whenever the efferent arteriole is dilated, what do you think will happen to the GFR? The GFR will decrease. So, his GFR is decreasing. Okay, that is the reason why the creatinine levels in the body are rising slightly. Okay, so this is the reason. So, what is my main goal here is to make you understand this area is very, very important. The conditions where the GFR level increases and the conditions where the GFR level decreases. Okay, afferent arteriolar constriction. See, afferent arteriolar constriction decreases the GFR. Afferent arteriolar dilation increases the GFR. Exactly in the same way, efferent arteriolar constriction, say mild efferent arteriolar constriction increases the GFR, efferent arteriolar dilation decreases the GFR. Okay, so efferent arteriole is very important. Again, I am repeating, mild efferent arteriolar constriction increases the GFR. But severe, if they use the word severe efferent arteriolar constriction, actually can decrease the GFR. That is called as a biphasic response. Even in the classes we have discussed this. Okay, so the main aim, my main motto is that to make you understand this area is very important, where the conditions where the GFR increases and the conditions where the GFR decreases. Okay, so what is the answer? Here the answer is decreased efferent arteriolar tone. Okay, efferent arteriole constriction decreases. Efferent arteriole will undergo dilation. Okay, next, a 50-year-old male presents with progressive weakness. Okay, more in the proximal limbs. Okay, which improves with activity. Okay, EMG electromyogram shows incremental response, means betterment is there, progressive betterment with a repetitive stimulation. Okay, see here the most important thing is the progressive betterment after repetitive stimulation. The more you use the muscles, the more they the better they become. Okay, so more you stimulate, the better response is going to be seen. See, this is a classical feature of what? Lambert-Eaton myasthenic syndrome. Lambert-Eaton myasthenic syndrome. Okay, tell me, in myasthenia gravis, what happens in myasthenia gravis? It is progressive worsening. The word is progressive worsening. The early morning, see, first of all, I am the person with the myasthenia gravis. Imagine I am the one with the myasthenia gravis. If I am the one with the myasthenia gravis, early morning, okay. But the more I use my muscles, the worsen they become. They will become more and more worsened by the evening. So that is called as early, that is called as the evening weakness. But early morning weakness is seen with what? It is seen with the Lambert-Eaton myasthenic syndrome, where in the early morning, muscles are going to be weak, but you use the muscles, okay. If you are using the muscles again and again, they are becoming better. So yes, this question is clearly talking about Lambert-Eaton myasthenic syndrome, okay, which can be a paraneoplastic manifestation of small cell carcinoma of the lung. See, this is the main problem. Small cell carcinoma of the lung, you know, it produces different types of hormones. Small cell carcinoma of the lung can sometimes produce the antidiuretic hormone leading to SIADH. The small cell carcinoma of the lung can sometimes lead to Lambert-Eaton myasthenic syndrome. So tell me, what happens in Lambert-Eaton myasthenic syndrome? In Lambert-Eaton myasthenic syndrome, look, sir, here is the nerve terminal. Let's say this is the nerve terminal. In the nerve terminal, what do we have? Voltage gated calcium channels will be there. So you are producing antibodies against this voltage gated calcium channels. Antibodies are produced against the voltage gated calcium channels. Okay. Normally, whenever the action potential is coming, see, whenever the action potential comes, the calcium will go into the nerve terminal. Calcium will help in exocytosis of acetylcholine. Acetylcholine, what it will do? It helps in the muscle contraction. But today what happened? Today you are producing autoantibodies against this voltage gated calcium channels. That is a Lambert-Eaton syndrome. Okay, the more you stimulate this neuron, see, the more you stimulate these neurons, these antibodies will move away. So the muscles will become better. Okay, so here the problem is antibodies against presynaptic calcium channels. It's a voltage gated calcium channels which are getting attacked by the antibodies. Okay, next, what is a motto? What is my motto? Here my motto is, in your exam they will ask early morning weakness. Early morning weakness, it is Lambert-Eaton myasthenic syndrome. Evening weakness, that is myasthenia gravis, where autoantibodies are produced against the acetylcholine receptor. See, antibodies against the acetylcholine receptor, then your answer will be myasthenia gravis. Okay, so that's my motto. Always see, Lambert-Eaton myasthenic syndrome, it is always early morning weakness. Myasthenia gravis, evening weakness. Progressive worsening means myasthenia gravis. Progressive betterment, that is Lambert-Eaton myasthenic syndrome. Okay, so done. Next, a 32-year-old male presents with a complaint of fatigue, dark color urine early in the morning, okay, and episodes of abdominal pain. He has no history of recent infection or drug intake. On examination, there is mild pallor and splenomegaly. Look at the lab investigations. Hemoglobin is less, anemia is there, more reticulocyte count, LDH levels are more. Next, in urine there is hemoglobinuria, and flow cytometry shows a deficiency of CD55 and CD59. It's a very classical case of what? Paroxysmal nocturnal hemoglobinuria. This one you have already studied in your medicine, also, in your patho also, in our physiology classes also we have discussed this. Okay, paroxysmal nocturnal hemoglobinuria, which is an acquired hemolytic anemia, intravascular hemolysis due to deficiency of which protein? GPI deficiency. No CD55 on the blood cells, no CD59 on the blood cells. So what happens is, see, in these fellows, during night especially, there's going to be mild acidosis. That mild acidosis is going to activate the complements called as a membrane attack complex. Complement proteins are activated. Membrane attack complex will try to kill my own RBC, WBC platelets. So my RBC, WBC and platelets are getting attacked by the membrane attack complex. So RBCs will undergo hemolysis. So RBC hemolysis, RBC rupture is going to leak the hemoglobin into the blood, and from the blood the hemoglobin is going to leak into the urine. That's why hemoglobinuria. Okay, that's why this condition is called as a paroxysmal nocturnal hemoglobinuria. Means during night there is hemolysis. Why there is hemolysis? Because during night slight acidosis in the body. Okay, slight respiratory acidosis will be there. That respiratory acidosis activate our complement proteins. Complement proteins attack our own blood cells. When, if you are having deficiency of CD55 and CD59. So my motto is this topic is very important for your exam. Paroxysmal nocturnal hemoglobinuria, where you are having deficiency of what? CD55 and CD59. They are also called as a DAF and MERL. That is the decay accelerating factor and membrane inhibitor of reactive lysis. If you are having deficiency of these two proteins on your RBC, that is going to cause the hemolysis. Your RBCs will be affected. Okay, so this area also very much important for your exams. So now tell me what is happening. Sir, here the membrane attack complex mediated intravascular hemolysis. Yes, membrane attack complex is attacking your own blood cells. Tell me, autosomal dominant or autosomal recessive? No, this is an acquired condition, not a hereditary thing. It's a acquired condition. Which gene mutation? PIGA gene mutation. Okay, PIGA gene mutation. What is the gold standard investigation of choice? Flow cytometry. Deficiency of CD55 and 59. Okay, this is all due to loss of which protein in the cell membrane? See, in your cell membrane, there is a protein called as GPI. So this GPI is the one which is holding CD55 and CD59. So whenever you are losing this GPI from the cell membrane, CD5 and CD59 are going to be deficient, and that is going to cause the hemolysis, intravascular hemolysis. Okay, what is the most common cause of death? What is the most common cause of death in the paroxysmal nocturnal hemoglobinuria? The most common cause of death is thrombosis. Okay, and usually the patients of paroxysmal nocturnal hemoglobinuria are also going to suffer with the Budd-Chiari syndrome. Okay, portal venous thrombosis is going to be there, and that will lead to Budd-Chiari syndrome, and that is one of the most common cause of death in paroxysmal nocturnal hemoglobinuria. Chalo. So all the important points were given here. Once the session is completed, the entire PDF will be shared in your Telegram group. Okay, in SAR's Telegram group. Next, a 5-year-old boy is brought to the pediatric clinic with a progressive difficulty in walking. Okay, a child having difficulty in walking. His parents report that he frequently falls and struggles to climb stairs. Okay, his calves appear enlarged. Means by this time you should be able to think, child, difficulty in walking, calves appear bulky. This is pseudo calf hypertrophy, Duchenne's muscular dystrophy, Gover sign positive. Okay, see, on examination there is a proximal muscle weakness. Okay, especially the pelvic girdle muscles are weak. Okay, serum creatinine levels are rising. What is the underlying pathology? You know, this is what? Duchenne's muscular dystrophy with a positive pseudo calf hypertrophy, and he is also going to demonstrate Gover sign, which means upon asking this fellow to stand up from sitting position, if you ask the person to stand up, he will use the support of the upper limbs to rise his body. That is called as a Gover sign. Now tell me, this Duchenne's muscular dystrophy, it is due to what? It is due to the complete absence of which protein in the cell membrane? It is due to complete absence of a protein called as dystrophin. The dystrophin protein is totally gone because of the mutation of dystrophin gene on chromosome number X chromosome. You know, this dystrophin gene is the largest gene in the humans. It's the largest gene. Dystrophin gene is the largest gene. Okay. So, you know, the two important things are pseudo calf hypertrophy. Second one, pseudo calf hypertrophy. Second one, Gover sign positive. Muscle weakness. Okay. Muscles are dying. So, when the muscles are dying, myoglobin will leak. Creatine kinase will leak from the muscles. Okay. So, that myoglobin will leak into the blood, and that will lead to myoglobinuria also. Okay. Next. So, what is the answer here? The answer is mutation of dystrophin gene. Next. A 3-year-old male infant is brought to the pediatrician for generalized swelling, poor feeding, reduced urine output. On examination, the baby has severe anasarca. Anasarca means what? Anasarca means generalized swelling, generalized edema. Urine analysis reveals Massive proteinuria, okay, means, I know, massive proteinuria in a child, definitely this is a nephrotic syndrome, okay. And serum albumin levels is 1.2 gram per dl. There is also hypogammaglobulinemia, means albumin levels are less, gamma globulin levels are less, and increased susceptibility to infection. See, this is a classical case of what? This is a classical case of nephrotic syndrome where the person is losing the albumin. Loss of albumin decreases the oncotic pressure in the body. Whenever the oncotic pressure decreases, there is going to be edema. Whenever the boy is losing the globulins, loss of antibodies is going to cause the infections. So yes, this is a nephrotic syndrome. Genetic testing reveals a mutation of nephrin. Now I know, nephrin and podosin. Nephrin and podosin, this area is important from your patho and physio. Nephrin and podosin. Okay, what do they form? Nephrin and podosin, sorry. Just give me a minute. Yeah, nephrin and podosin, they are the ones which is forming the slit diaphragm. Okay, they are the ones which forms the slit diaphragm. Now, slit diaphragm is the one which prevents the loss of proteins. Today what happened? Today nephrin is going to be defective. Why? What might be the reason? Nephrin is defective, that is due to NPHS1 gene mutation. NPHS1 gene mutation, nephrin will be nephrin is going to be defective, the protein is going to be defective, so automatically slit diaphragm is going to be defective, that is going to cause a proteinuria. So this is called as a Finnish type of nephrotic syndrome, seen in the Finland people, okay, very much common in the Finland people. So the answer here is nephrin defect, so it is Finnish type of nephrotic syndrome. NPHS2 gene mutation is going to cause a defect in podosin, that is going to cause steroid resistant nephrotic syndrome. Okay, so this area also very much important for your exam. Finnish type of nephrotic syndrome, steroid resistant nephrotic syndrome, minimal change disease. Minimal change disease also going to cause a selective albuminuria in a children who had a recent vaccination, who had a history of recent vaccination or recent infections. Okay, so that is a minimal change disease where there is a selective albuminuria. But here in Finnish type of nephrotic syndrome, not only the albumins but also globulins will be lost. Okay, chalo. Next, question 6. A 4-year-old child is brought to the pediatric clinic for the evaluation of failure to thrive, polyuria, bone pain. On examination, the child has rickets-like deformities, okay, severe dehydration. Laboratory results reveal these things. Okay, so what is the most likely diagnosis? So here the baby is having the metabolic acidosis with the normal anion gap. Okay, this NAGMA, NAGMA. See, the moment I see NAGMA, NAGMA, the first thing that comes to my mind always is the renal tubular acidosis cases. Renal tubular acidosis type 1, type 2. They are the reason. They are one of the example for the normal anion gap metabolic acidosis. Okay, so now I am thinking about the renal tubular acidosis. See, here the option is renal tubular acidosis type 1 is there. Okay, but wait, is the answer renal tubular acidosis type 1 or not? Let's check. See, here there is a hypokalemia, glucosuria, hypophosphatemia, amino acid loss, bicarbonate loss. Now I know what is the answer. See, glucose loss, amino acid loss, bicarbonate loss, phosphate loss, potassium loss, everything is getting lost, which means this person is having defect in the PCT. Okay, so in the PCT, the glucose which was supposed to be reabsorbed, amino acid which was supposed to be reabsorbed, 100% is not getting reabsorbed. So this condition is called as, means global defect in the PCT transporters. The entire PCT transporters are not working. No sodium reabsorption, no glucose reabsorption, no amino acid reabsorption, no phosphate reabsorption, no bicarbonate reabsorption. So everything will be lost into the urine. So this condition is called as Fanconi syndrome. Fanconi syndrome. Okay, and one more thing, sir, this person is unable to reabsorb the bicarbonate. The person is unable to reabsorb the bicarbonates. As he is unable to reabsorb the bases or bicarbonates, this fellow will go into the acidosis. That too, renal tubular acidosis type 2. So Fanconi syndrome is a classical case of RTA type 2 where the bicarbonates are not getting reabsorbed into the blood. Bicarbonate loss. So because of the problem in the renal tubule, that's a renal tubular acidosis type 2, which is a PCT defect. Okay, so yes, this condition is Fanconi syndrome. RTA type 1 is DCT defect, proton pump mutation, DCT defect, where there is inability to excrete the H+, inability to excrete the H+. Okay, so here what is the problem? Here the problem is with the PCT. That's why glucose is lost into the urine, amino acids are lost into the urine, phosphates are lost, potassium is lost, bicarbonates are lost into the urine. If you are losing the bicarbonates, you are not able to reabsorb them, if you are losing the bicarbonates, it is RTA type 2, Fanconi syndrome. Fanconi syndrome. Okay. Chalo, next, what is Fanconi syndrome and what happens in Fanconi syndrome and what are the causes of Fanconi syndrome? Everything is given over here. Just now I have taught you bicarbonate loss will lead to acidosis in the body, that is called as RTA type 2, where there is a defect in proximal convoluted tubule. RTA type 1 is a defect in the DCT. Okay. Chalo, next. A 15-year-old African boy had a severe pain and lower back, pain in his lower back also. For the past 12 hours, he had a history of recurrent episodes of similar pain. So it's not one time, he had repeated episodes of such pain. Often precipitated with cold weather and dehydration. Okay. He is pale, febrile and distressed. There is scleral icterus, tenderness over the long bones. His lab report shows hemoglobin anemia is there. MCV, mean corpuscular volume 88 femtoliters. Reticulocyte count is increased. So first of all, anemia and reticulocyte count is increased. Peripheral smear shows sickled RBCs. That's it. The diagnosis is done. It is sickle cell disease. Okay, even target cells are seen. Hemoglobin electrophoresis shows 85% of HbS. Hemoglobin S, sickle cell hemoglobin, 85%. Now I know if it is a sickle cell disease, the RBCs are undergoing sickling, especially with the dehydration. Especially with the dehydration hypoxia, the RBCs will sickle, and the sickled RBCs will occlude the blood vessels, will occlude the blood going to the bones. That is going to cause this vaso-occlusive crisis. Blood vessels are getting occluded. Vaso-occlusive crisis is the one responsible for this bone pain. So yes, what is the reason? The reason is pain is due to vaso-occlusive crisis. Okay, vaso-occlusive crisis. So yeah, look here in a person with the sickle cell disease. Just now, see triggers. What are the triggers for the sickling? That sickling, every time the RBCs are undergoing sickling, desickling. So what are the main triggers? Cold, dehydration, infection, hypoxia, acidosis. These are all the triggers which are very important for your exam. Remember, hypoxia and dehydration are very important triggers. Okay, so what are the key crises? Sir, the blood vessels will be occluded, especially the blood going to the bones will be occluded, and that's going to be responsible for the bone pain. That is going to be responsible for the bone pain. And hemoglobin electrophoresis always show increased HbS. Okay, and sickle cell disease, very important for your exam. You know everything about the sickle cell disease. Okay, so what is the what is that? It's a point mutation, right? Okay, the glutamic acid will be replaced with the valine. You know, already know glutamic acid will be replaced with the valine in the position number 6 of beta globin chain. You already know it, but anyway. Next, a 42-year-old man presents with a progressive involuntary jerky movement. So involuntary jerky movements means, you can understand, these are abnormal movements due to damage to basal ganglia structures. Usually damage to the basal ganglia is going to cause these problems. For the past 6 months, his wife reports he has become increasingly irritable, forgetful, and shows signs of depression. He has a family history of similar illness to his father, who died in early 50s. Okay. On examination, he demonstrated chorea. Now this is the keyword. Chorea. The moment I think about the chorea, always one disease will come into my mind. So one is Sydenham's chorea, that is rheumatic heart fever. Rheumatic heart fever, there is a Sydenham's chorea is going to be there. Another thing is a Huntington's chorea. Okay. So impaired memory and slow saccadic eye movements. Now what is the most likely diagnosis? the most likely diagnosis, I have told you, it is a Huntington disease. In Huntington disease, there is going to be something called as like a CAG repeats. Okay, trinucleotide repeat disease. The CAG, C-A-G, trinucleotides are getting repeated again and again in the genome. So that is going to be responsible for the involuntary movements in this condition. Okay, definitely it's not Sydenham's chorea. Okay, because here the person age is 42 years. Sydenham's chorea, it is going to be seen in rheumatic heart disease where the child is going to be somewhere around 10 to 15 years of age. Here the person is having 42 years. By 42 years he is manifesting these symptoms. His father died at early 50s. Means he developed this disease very early when compared to his father age, which means this is called as something called as the anticipation. Okay, anticipation is going to be seen with the trinucleotide repeat diseases. In path also you have studied this, in medicine also. Okay, so see, sir, this Huntington disease is an autosomal dominant disorder due to trinucleotide repeat expansion. CAG, C-A-G, trinucleotide repeats are going to be expanded. Anticipation occurs due to repeat expansions in the successive generation. Means when a father is having disease by 50 years of age, the offspring is going to have this disease early when compared to, due to this expansion of this trinucleotide repeats, when compared to father, the disease is going to be more early in onset in the offspring. That is called as anticipation. Okay, and what is happening? Because of this trinucleotide repeat expansion, there is the damage to, leads to degeneration of GABA neurons. GABAergic neurons or the inhibitory neurons are going to get damaged in the caudate nucleus and putamen. Have I taught you caudate nucleus and putamen? They are part of what? They are part of basal ganglia. Any damage to the basal ganglia is going to cause what? Damage to the basal ganglia is going to cause the involuntary jerky movements. Okay, and that too here the inhibitory neurotransmitters are getting damaged. So whenever the inhibitory neurons are getting damaged, the GABA neurons are getting damaged, there is going to be overexcitation of the motor pathways, and that is going to cause the abnormal movements. Okay, so yes, the answer here is Huntington disease. See, in Wilson disease, you know, it's a hepatolenticular degeneration where there is too much amount of copper deposition in the body. And Parkinson's, you know, it is rigidity, echinacea and tremors. What kind of tremors? Resting tremors are going to be seen where it's problem with the movement. See, here there is no movement. Parkinson's there is no movement. In Huntington's there is too much involuntary movement. Okay, dementia means you already know it's loss of memory. Okay, so yes, Huntington disease is very important for your exam. Next, a 36-year-old man presents with a fever, fatigue, weight loss. For the past 2 weeks on examination, he has tender nodules on fingertips. Okay, tender nodules on fingertips. Okay, and a pansystolic murmur at the apex radiating to axilla. Means a pansystolic murmur radiating towards the axilla. See, what are the possibilities of the pansystolic murmur? Pansystolic murmur or holosystolic murmur? MR, TR, VSD, MR, TR, VSD. That's mitral regurgitation, tricuspid regurgitation, ventricular septal defect. Okay. Fundoscopy reveals Roth spots. That's it. Keyword, buzzword. Roth spots is the buzzword. You know what is this? Roth spots, and urine microscopy shows microhematuria. So I know. So what is this condition? So this is infective endocarditis. In infective endocarditis, painful nodules. Ouch. That is osler knots. Osler knots are painful. Painless lesions are called as Janeway lesions. Okay, Janeway lesions are painless. Osler knots are painful. Roth spots are going to be seen. Modified Duke's criteria. You already know all these things. Okay, so infective endocarditis is very, very important. Now, which of the following best explains the mechanism of renal findings in this patient? Okay, so let's say he is having microscopic hematuria is there. Now, what is happening? See, here in infective endocarditis, what do we produce? In infective endocarditis, antigen is there. Now, antibodies are produced against them. Antigen antibody complexes, or you can say the immune complexes which are circulating in the blood. The immune complexes which are circulating in the blood, they will go and deposit in the kidneys. And this immune complexes always activate what? The immune complexes, antigen antibody complexes, they will activate the complement proteins. And complement activation is going to cause the damage to the kidneys, and that is what is causing the microscopic hematuria. Okay, so here the answer is immune complex mediated glomerulonephritis. It is because of the autoimmune, it is because of the antigen antibody complexes which are circulating in the blood. These circulating antibodies are getting deposited in the kidney, activating the complement system, and the complement system is going to cause the damage to the glomerulus, and that's what is causing the microscopic hematuria. Okay, so here is the answer. So infective endocarditis, very very important. Where is the site of vegetation? Important. What are the most common agents causing the infective endocarditis? Okay, agents causing the infective endocarditis. Okay. Next, what they will ask you, what are the criteria for infective endocarditis? What are the major criteria? What are the minor criteria? Like that's a modified Duke's criteria, right? So they should, you should, those things you should know. Okay. So anyway, here I have given the important things. Look here, immunological sign. Antigen antibody complexes are going to deposit in your kidneys. Not only in your kidneys, also in your blood vessels. They are going to cause the oscillar nodes. Oscillar nodes are always tender. Okay, tender. Hematuria. Why hematuria? Because of damage to the glomerulus. Why there is damage to the glomerulus? Due to immune complexes deposition. Immune complexes deposition. Okay, so immune complexes deposit in the glomeruli, activate the complements. Complements are going to cause the glomerulonephritis. Okay. So what are the criteria for the Dukes? Okay, modified Dukes criteria. Major criteria are there and some minor criteria are also there. You can go through that later. Next, question number 10. A 25-year-old male athlete is admitted for the evaluation of acute dehydration after running a marathon. He is having acute dehydration. Okay. In extreme heat. On examination, he is hypotensive and has dry mucous membrane. Okay. He is totally dehydrated. Lab show elevated blood urea nitrogen. Okay. And creatinine levels. His GFR is reduced. Which of the following best explains how tubuloglomerular feedback acts to increase the GFR in this situation? Look carefully. Now, his GFR decreased. Okay, his GFR is decreased. Now tell me, is it good or bad? It's bad. His GFR is decreasing. Okay, his GFR is decreasing. Too much decrease of anything is bad. You have to maintain the GFR. You have to maintain the GFR. How you can maintain the GFR? Via the tubuloglomerular feedback mechanism. I have taught you the tubuloglomerular feedback mechanism maintains the GFR, level. How? How it maintains the GFR levels? Okay. Let me tell you, today what happened to his GFR? First starting his GFR reduced because of the severe dehydration. His GFR reduced. So look at carefully here. Now here in this person there is less GFR reduced. So tell me what happened to the sodium chloride? Sodium chloride also less sodium chloride filtered. Now this less sodium chloride is going towards the which cells? Macula densa. This is the macula densa cell. Okay, sitting at the junction of thick ascending limb of loop of Henle and DCT. In the junction of thick ascending limb of loop of Henle and DCT, there is a cell sitting and that cell is called as a macula densa. So now tell me, less sodium chloride is coming here. So less sodium chloride will go into the cell. Okay. So inside the cells, sodium chloride levels are going to be less. So less sodium will go out and less potassium will come in. So what is the name of this pump? This is sodium potassium pump. Sodium potassium pump. So tell me, if less sodium is available here, less sodium will go out and less potassium will come in. So the activity of the sodium potassium pumps is going down. Less ATP is broken down. So here ATP broken down decreases. So less adenosine is produced in the cell. We know the macula densa cells produces what? Adenosine. So today less sodium chloride, once the less sodium chloride comes here, less adenosine is produced. I have taught you adenosine function is what? Adenosine function is to do vasoconstriction, afferent arteriolar vasoconstriction. Today adenosine levels decreases. So do you think afferent arteriole will undergo vasoconstriction? No. So today afferent arteriole will undergo vasodilation. Afferent arteriolar vasodilation, more blood will come to the glomerulus, more will be the GFR. Okay. So what is the answer here? Decreased sodium chloride, right? Decreased sodium chloride delivery to the macula densa, causing decreased production of the adenosine, so leading to afferent arteriolar vasodilation. So how to increase the GFR? Afferent arteriolar vasodilation. Simple. Okay. So that's the answer. What you should know, what are the mechanisms by which the GFR is maintained? One is a tubuloglomerular feedback with the help of which cells? Macula densa. And one more mechanism is that is called the myogenic mechanism. Myogenic mechanism also helps in the maintenance of the GFR. Okay. So done. Next. Look at this question. A 38-year-old man presents with lethargy, postural dizziness and salt craving. Okay, salt craving is a keyword. Okay. He has a diffuse hyperpigmentation and a blood pressure of 88/56, means hypotension is there, low BP. Okay, I know salt craving, hyperpigmentation, low BP. This is all the classical case of what? Addison's. This is all the classical case of Addison's disease. Hyperpigmentation due to ACTH levels, you know, Addison's disease. So they're asking, which of the following best describes body fluid compartment change in this patient? Now, try to understand like this. Try to understand. Here I am showing you ICF, intracellular fluids, and here I am showing you ECF, extracellular fluid. Okay. So ICF, ECF, intracellular fluid, extracellular fluid. Today in Addison's, you tell me, in Addison's, there is a decrease aldosterone. Okay, decrease aldosterone. Whenever aldosterone level decreases, what happened to the blood sodium levels? The blood sodium levels will decrease. Extracellular fluid is nothing but the blood. So decrease sodium, decrease sodium. So tell me, whenever the sodium is decreased, osmolarity will decrease. Osmolarity will decrease. What is the normal osmolarity? ICF osmolarity 300, ECF osmolarity 300, starting with 300. But today what happened? Because of low aldosterone levels, aldosterone deficiency, the sodium levels will decrease in the blood. Whenever the sodium level will decrease, osmolarity, let's say it becomes only 280. Osmolarity decrease. You know, according to the law of osmosis, fluids always go from low to high osmolarity, low to high. Wherever there is more sodium, fluid will start to go towards the high sodium. So tell me, extracellular fluid will decrease, intracellular fluid will increase. Okay, intracellular fluid will increase. So yes, in this fellows, the intracellular fluids are going to increase, extracellular fluids are going to decrease. Okay, so what is happening here? So in this condition, look carefully, the extracellular fluid should decrease. Yes, extracellular fluid is decreasing and intracellular fluid is increasing. Okay, na? This is the answer. This is the easiest way to identify, because extracellular fluid is decreased and intracellular fluid is increased. Addison's is also called as what? Adrenal insufficiency. Agreed or not? Addison's is also called as adrenal insufficiency because there is no aldosterone, no cortisol. How to remember this for your exam? Let me give you a trick. In adrenal insufficiency, I is increasing. Adrenal insufficiency, I is increasing. What is I, sir? Intracellular fluid will increase. Adrenal insufficiency may I increases, that is the intracellular fluid will increase, extracellular fluid will decrease. Okay? Done? Chalo. So B is the answer. Okay. Next, here is the explanation given. You can go through the explanation. A 12-year-old man presents with the acute onset of muscle weakness, okay, after consuming contaminated food. On examination, he had flaccid paralysis, but sensation and mental status are intact. Nerve conduction studies are normal. He was diagnosed with botulism. That's it. Botulism, Clostridium botulinum is the one doing it. Canned food poisoning, canned foods, sporulated honey ingestion. Okay. Which of the following mechanisms is most directly impaired in skeletal muscle contraction? See, look, this is the nerve terminal. Here is the nerve terminal. Here is the neuromuscular junction, and here is the muscle. Okay. Here is the muscle. Normally, here is a vesicle. Okay. Here is a vesicle which contains the neurotransmitter acetylcholine. Now, which substances or which protein helps in the exocytosis process? Exocytosis process mein snare proteins, look carefully here. This is called as a synaptobrevin and this protein is called as a syntaxin. Synaptobrevin and syntaxin, which are examples of snare. Which are examples of what? Snare proteins. Today, whenever you are having this botulinum toxin in your body, botulinum toxin, what it will do? Okay, this Clostridium botulinum is going to produce a toxin called as a botulin. This botulin toxin enters into our neurons. After entering into your neurons, this botulin, it will come and it damages snare proteins. So, from the presynaptic membrane, acetylcholine, is it released? No, acetylcholine is not released.
Without acetylcholine, do you think the muscle will contract? No, muscle is not going to contract. So tell me, what is the mechanism of action? Which process is inhibited? It is the release of acetylcholine from the presynaptic membrane. Release of acetylcholine from the presynaptic membrane due to the damage to which proteins? Snare proteins. So you should know. Sir, exocytosis के लिए, for exocytosis who is helping? Snare proteins and calcium. Endocytosis करने के लिए, sir, endocytosis requires clathrins and caveolins. Clathrins and caveolins are involved in endocytosis. Calcium and snare proteins are involved in exocytosis. Snare proteins are damaged due to botulin toxin. Botulin. Okay. So what is the answer here? Which mechanism is affected? Release of acetylcholine at the neuromuscular junction. Okay, acetylcholine, now it's not going to be released. So that is going to lead to floppy baby syndrome, descending flaccid paralysis. Okay. So look at here, botulism toxin cleaves which proteins? Snare proteins. Prevents the release of acetylcholine from the presynaptic terminal, leading to descending flaccid paralysis. Okay, done. 13th question. 30-year-old man presents with rapidly progressive weakness in both lower limbs. Okay, rapidly progressive weakness is a which has ascended to involve the upper limbs over the 3 days. Okay, so it is a very classical case. The weakness started in the lower limbs and it is ascending up. So it is ascending flaccid paralysis. Ascending. Previously what we have discussed, sir, here we have discussed about the descending flaccid paralysis. That is botulism. Descending flaccid paralysis. But here now I am talking about ascending flaccid paralysis. The Guillain-Barré syndrome. Okay, that's you can say Guillain-Barré syndrome. Now, what they are asking? Okay, I know this is the Guillain-Barré syndrome without any doubt. And one more keyword is there. CSF shows what keyword? Albuminocytologic dissociation. Albuminocytologic, which means in the CSF there is more protein and normal amount of cells. This is called as albuminocytologic dissociation. Means when compared to the number of cells, the albumin levels are more. So if you see this word albuminocytologic dissociation, always think about the GBS. Okay, what is the following physiological processes is impaired in this patient? The GBS is a demyelinating disorder of the peripheral nerves. It's a demyelinating disorder. Normally, you know, if you look at a nerve, sir, here there will be myelination. Here there will be myelin sheath. Here there will be myelin sheath. Here there will be myelin sheath. So the action potentials are going to jump from one node of Ranvier to other node of Ranvier. From here to other node of Ranvier. This is called as a saltatory conduction, because wherever there is myelin sheath, here you cannot have the action potential because that myelin sheath are completely closing the membranes. So this is called as what? Saltatory conduction. Okay, the action potential is conducting, like jumping from one node of Ranvier to other node of Ranvier. So that will be affected. Today what is happening? So today there is demyelination. The myelin sheath is going to be lost. Whenever the myelin sheath is going to be lost, such saltatory conduction will be lost. Such saltatory conduction will be lost. Okay, so yes, saltatory conduction along the peripheral nerves will be affected because it's a demyelinating disorder. Guillain-Barré syndrome, that is due to which infection usually follows after the Campylobacter jejuni infections. Okay, you can go through the GBS later. Okay, so tell me which cells will be affected. See, Guillain-Barré syndrome or Guillain-Barré syndrome, it's a demyelinating disorder of the peripheral nerves. Who will cause the myelination of the peripheral nerves? It's the Schwann cells. Schwann cells will be affected. Okay, next 14th question. A 35-year-old construction worker accidentally hits his thumb with a hammer. Okay, he immediately begins to rub the injured area vigorously and reports doing so makes the pain feel better. So now what I'm trying to say here is, see, he had a hit, he is having pain right now. Upon doing massage in that area, rubbing in that area or giving cold packs in that area, now he is feeling less pain. Okay, now he is feeling less pain. That is, giving massage actually decreases the pain. What is this? Gate control theory, very important for your exam. Okay, gate control theory. What happens in gate control theory? Sir, actually pain is going like this. Through the C fibers, the pain is going like this. Now whenever you give massage, what will happen? Giving massage is going to activate the A beta fibers, large myelinated fibers are going to be activated. So from the same region, now C fibers are activated taking the pain. Now in the same region, if you give the non-painful stimulus or give massage, the A beta fibers will be activated, which are A means highly myelinated fibers are activated. So these highly myelinated fibers will inhibit the pain fibers. They will inhibit the pain signals, okay, going to the brain. So this is called as a gate control theory. We have discussed in our regular classes. So what is the answer? It is the inhibition of pain signals by the large myelinated fibers. Who is the large myelinated fiber in this case? A beta fiber. Giving massage will activate the A beta fibers in that area. So what is my motto? My motto is you to understand that gate control theory, very important. TENS apparatus, transcutaneous electrical nerve stimulation, TENS study works on the principle of gate control theory. A beta fibers, upon giving the massage, which fibers are activated? A beta fibers are activated. Okay, so you should also know that A alpha fibers. What are A alpha fibers? A beta fibers, A gamma fibers, A delta fibers, C fibers. What is the function? Okay, pressure is going to kill which fibers? Hypoxia is going to cause damage to which fibers? That area you have to focus in your books. Okay, so done. Next, look at the 16th question. A 45-year-old man presents with fatigue, joint pain and darkening of the skin. Okay, he also reports decreased libido. On examination, he has splenomegaly, bronze pigmentation. That's it. This is the keyword for me. Bronze pigmentation of the skin. Bronze pigmentation of the skin is a bronze diabetes. Bronze diabetes. Due to what? Bronze diabetes, it is due to too much iron accumulation in the body. That is iron overloaded state. Hemochromatosis. Hemochromatosis. Okay, too much iron overloaded state in the body. Okay, his blood glucose levels are elevated. Why the blood glucose levels are elevated? Because too much amount of iron accumulation in the pancreas is going to cause a pancreatic insufficiency. Pancreas is getting damaged. The beta cells are getting damaged. Less insulin levels in the body. Less insulin is going to rise the blood glucose levels. It's a classical case of hemochromatosis. Okay, which of the following is most likely cause of the patient condition? Hereditary mutation of HFE gene. Hereditary mutation of gene HFE. HFE stands for what? HFE stands for high iron. HFE gene mutation. HFE for high iron gene. Okay, so this person is going to absorb too much amount of iron in the body. Too much amount of iron in the body is going to cause a hemochromatosis. Okay, so look at here. What is the triad of symptoms? The triad of symptoms are going to be bronze diabetes. Okay, bronze, too much amount of iron deposition in the skin is going to give the skin bronze appearance. Okay, skin pigmentation, diabetes with liver dysfunction. Why liver dysfunction? Because of too much iron deposition in the liver. Okay, too much iron deposition in the liver is going to cause a repeated damage to the liver, and that can even lead to the cirrhosis. Okay, it's autosomal, yes, autosomal recessive disorder of HFE gene mutation. HFE gene important. Okay, done. See, there is too much amount of iron absorption from the intestine. Too much iron is going to be deposited in the liver, pancreas, skin, heart, joints, everywhere. Okay, so what is the chelating agent used in this condition? The chelating agent that we will use in this condition is defroxamine. Okay, defroxamine. 17th question. A 55-year-old male presents with the pedal edema. Okay, to understand the fluid dynamics in his lower limb capillaries, the following Starling forces are measured. Okay, so here we are having hydrostatic pressure and oncotic pressures of the capillary as well as the interstitium. Based on the Starling's equation, what is the net filtration pressure across the capillary wall? See, what is the formula to calculate the net filtration pressure? The formula is favoring forces minus opposing forces. Favoring forces of filtration minus opposing forces of the filtration. Favoring forces of the filtration minus opposing forces of the filtration. Now, look carefully here, my dear students. Sir, capillary hydrostatic pressure, it always tries to push the plasma into the tissues. It always tries to push the plasma into the tissues. So, yes, let's consider it as a favoring force. Okay, sir, it's a favoring force. Next, capillary oncotic pressure. It is always an opposing force. Capillary oncotic pressure, because of the albumin molecules, it doesn't allow the plasma to go into the tissues. So one is a favoring force, other is a opposing force for the movement of fluid out of the blood vessel. One favors the movement and other opposes the movement. Okay. Next, now in the interstitium, see, now we are going to talk about the interstitium. Interstitial hydrostatic pressure is an opposing force, but interstitial oncotic pressure is a favoring force. It's a favoring force. So now tell me, what is the formula to calculate the net filtration pressure? The formula to calculate the net filtration pressure is the favoring forces minus opposing forces. Okay, favoring forces minus opposing forces. Now tell me, how much is the favoring force in this condition? Favoring force, green plus green, favoring force, that is 40 plus 5, 45. So favoring force is 45 mm Hg. How much is the opposing force? Opposing force is 25 plus 2. 25 plus 2 is 27. So 45, that is the favoring force minus 27. And how much, you tell me? 45 minus 27. Okay, here it is given very clearly. See, if you don't understand, okay, look at here. Yeah, if you don't understand, here it's clearly given what is the favoring force, what is the opposing forces. See, favoring forces minus opposing forces. Tell me how much is the favoring force in our condition? 45. Minus 27, how much? 18. So the net filtration pressure is 18 mm Hg. Okay, that's the favoring forces minus opposing forces. Favoring forces minus opposing forces. Favoring force how much? 45, it is coming somewhere around. Opposing forces 27. That's it. Okay, next. Look at the next question, 18th question. A 50-year-old man with uncontrolled diabetes mellitus, okay, presents for evaluation. His plasma glucose concentration is 600, okay, and his glomerular filtration rate is 125 ml per minute. Assume the renal threshold for glucose is 200 milligrams per deciliter and transport maximum value is 375. Now they are asking how much glucose is excreted in the urine in this patient. Now, students, listen carefully. Tell me how to calculate the how much amount of glucose is excreted in the urine. First of all, tell me what is his plasma glucose concentration. His plasma glucose concentration is a 600. So 600 milligrams per deciliter. Deciliter meaning how much? 100 ml. So in 1 ml, 6 milligrams of glucose is there. This is the plasma glucose concentration, 6 milligrams per deciliter. Okay, fine. Now, tell me how much is the GFR? Sir, assuming the GFR is normal. Okay, GFR how much? 125 ml GFR is getting filtered. 125 is getting filtered. Tell me 1 ml mein 6 milligrams of glucose is there. So in 125 ml, how many milligrams? 125 into 6. 125 into 6 milligrams. 1 ml mein 6 milligrams. So 125 ml mein 125 into 6 milligrams. 125 into 6 how much? Sir, that will tell you the filtered glucose value. 125 into 6 will tell you the filtered glucose value. Now let me show you the calculation here. Okay, it's missing, but anyway, let me put it this way. 125 into 6. Tell me how much is 125 into 6? 125 how much? 125 250. Okay, 250 500 plus 250 how much? 750 milligrams per deciliter. So let's imagine here 750 milligrams of glucose is getting filtered per every minute. 1 minute mein. In 1 minute 750 milligrams of glucose is getting filtered. Out of this 750, how much do you think can be reabsorbed? Is the transport maximum value. The transport maximum value for the glucose is 375 milligrams per minute. Okay, out of this 750, how much he is reabsorbing? He can reabsorb up to 375 milligrams. Okay, so now tell me how much glucose is getting excreted into the urine. How much glucose is excreted into the urine? It should be 275, right? Just wait. So yes, here the better answer is how much glucose is excreted? Almost out of 750, here option was not given. Out of 750, 375 is reabsorbed. So how much is lost? It is 275 milligrams of glucose lost in urine every minute. 270. Okay, 5. 275 milligrams of 275 milligrams of glucose is lost in the urine every minute. So this is the correct answer. Okay, done. So now tell me how to calculate the amount of glucose that is excreted in the urine. The amount of glucose excreted in the urine is simple. First, calculate the plasma glucose concentration. Every ml, in every ml, how much glucose is there? 6 milligrams. So GFR into 6. GFR into 6, how much? 125 into 6. 125 into 6, 750. 750. Out of this 750 mein, how much he can reabsorb? 375. So 750 minus 375 is 275. So the answer is 275 milligrams per minute. Done. Next, 19th question. 60 kg man is brought to the emergency room after heat stroke and dehydration. Okay. To calculate his fluid loss, you decide to estimate his extracellular fluid, okay, and plasma volume. Now, assume his total body water is 60% of the body weight. ECF is 1/3 of the total body water and plasma volume is 1/4 of the extracellular fluid. What is the estimated plasma volume? See, this is a little tricky question, full of calculations. First of all, tell me, his total body water is 60% of the total body weight. Now, first we have to calculate the total body water. How much is the total body water? How much amount of body water is there? Look at this step-by-step calculation. First, what we need to do, we need to do the calculation of the total body water. Sir, his body weight is 60 kgs. 60 kgs. So 60% of his body weight, 60% of his body weight is because of the water. So 60% of 60 kgs, how much? 60% of 60 kgs is 36 liters. Okay. So his total body water is 36 liters. Okay. So right now, for example, I am 70 kgs. In 70 kgs, 60% of the total body weight is water. How much? 42 liters. Imagine I am 70 kg. I am 70 kg. So in 70 kgs fellow, 42 liters of total body water will be there. But here, the person is 60 kgs. 60 kg mein 60% is how much? 36 liters. Okay. Now we have calculated the total body water. After calculating the total body water, now we have to calculate the extracellular fluid. How much is extracellular fluid? They have told 1/3 of the total body water. 1/3 of the total body water is the extracellular fluid. Okay. So 36 divided by 3. 36 divided by 3. That is 1/3. 1/3. Okay. So how much is that? 12 liters. Okay. 12 liters is the extracellular fluid. 12 liters is the extracellular fluid. Now what we have to calculate? We have to calculate the plasma. In the question they have told, 1/4 is the plasma volume. Extracellular fluid mein, actually look, extracellular fluid mein 3/4 is interstitial fluid and 1/4 is plasma. We already know this from our classes. Now you know how much is the extracellular fluid? 12 liters. 12 liters mein how much plasma is there? 1/4. So 12 divided by 4. 12 divided by 4 how much? 3 liters. So plasma is 3 liters. 3 liters. Okay. So this is how to calculate. Now tell me how much is the plasma volume? 3 liters. 3 liters. Because see, in the question they have clearly given 60 kgs man. In 60 kgs man, how much total body water is there? 36 liters of total body water. In that 36 liters of the total body water, how much is the ECF? 36 divided by 3. That is 12 liters. Is 12 liters mein how much is the plasma? 12 divided by 4. 12 divided by 4. That is the 3 liters. 3 liters. Okay. Because for those students who doesn't understand, see, total body water. Let me write here. Total body water is divided into 2 compartments. Intracellular fluid, that is a 2/3, extracellular fluid 1/3. Extracellular fluid is further divided into interstitial fluid and plasma. Interstitial fluid is 3/4, plasma is 1/4 of the extracellular fluids. Okay, this thing you should know. Chalo, next. 20th question. A 50-year-old man is undergoing renal functional evaluation. He has given a substance that is freely filtered, not secreted and not reabsorbed. You know, this is inulin, nothing but inulin. His lab values are given. How much is the urinary concentration, urine flow rate, plasma concentration, everything is given. What is estimated GFR in this fellow? You know what is the formula to calculate the GFR of the person? GFR are the clearance. The formula that I use is UV by P. UV by P is the formula to calculate the GFR. UV by P. What is the U given in this condition? U value in this condition is 100. V value, how much urine is getting produced? V. Volume of urine produced per minute, 1 ml. By what is the P value? The P value in this condition is 2. So 100 divided by 2, how much? 50 ml per minute. So this is the GFR in this 50 ml per minute. Okay, so with this successfully what we have completed the 20 questions. Okay, these are all the important integrated questions, physiology integrated with the medicine. So I want you to go through these questions. Okay, hope the session is helpful. Thank you.